I'm Professor Sivan. I'm one of the co-chief investigators for the LOCOMOTION project. This is the second in our series of webinars from LOCOMOTION. These are monthly webinars. The ones who joined us last month, we did a couple of topics based on the findings from LOCOMOTION. We presented data on good practice for detecting dysautonomia and the NASA lean test in clinics. And we also presented findings from validating the C19 virus PROM. So just a few quick intro slides about our project. Apologies for the one who joined us last time, might be repetitive, but I'll keep it very brief, just a couple of minutes. Next slide. So we are a consortium of 8 universities and 10 NHS sites across the 3 UK nations. Next slide. So we've got a long list of investigators. Many of them you will know very well. And many thanks to Thomas Osborne, who's actually made all these webinars come alive very well. So a big thanks to him. Next slide, please. So those are our different work streams and work tasks. So today's focus is 1.3, improving health inequalities. And the idea is to try to understand how representative the clinics are at the moment and what needs to be done to improve that. So next slide, please. And those are all the sites. So at this point, I would hand over to 1.3 team led by Professor Ghazala. Thank you very much.
Thank you, Manoj. So a warm welcome to you all, and thank you for joining today's second webinar. So as Manoj introduced us, so I'd just like to introduce Professor Ghazala, Dr. Jordan Mullard, and myself, Sophie Evans. Next slide. Okay, so we just wanted to quickly talk to you a little bit about the overview for today's webinar this lunchtime. So I'm going to start off by talking about my personal patient experience with long COVID and how this contributed to the patient input of the work package. I'll then hand over to Dr. Jordan Mullard, who will present the findings for the patient experience of those who were interviewed for this work package. We will then have our first Q&A on patient experience, and then Professor Ghazala will present the findings on clinical practice and the ways forward, and she will then finish with the final Q&A on what good practice looks like. Next slide, please. So it's probably impossible to summarise my entire experience of long COVID. So I am going to try and keep this as brief as possible, but it's just to give everyone a sort of flavour of what's happened and how this matters and how it probably represents a similar, not the same, but definitely a similar story for a lot of patients that's having to go through long COVID at the moment. So I was one of the first waivers, if you like. I contracted COVID at the start of April in 2020 as a result of being on the NHS front line. I always like to highlight that I guess I was in the camp of being extremely young, fit, healthy. There was absolutely no past medical history. So that in itself, I do believe, created a slight barrier to accessing care, I think, as I reflect later on over the last 4 years. There were no risk factors either. So other than ethnicity, that would really sort of highlight the awful and difficult trajectory of the sort of COVID-19 and COVID experiences. I say ethnicity because for those of you who are the global majority, you might have remembered there was a lot in the media at the time about if you are global majority, you're likely to get COVID and perhaps even die from COVID. But I do recall never really understanding why. I guess probably because those from the global majority lived in sort of multi-generational households, also worked in jobs perhaps that had a higher risk of exposure to COVID. So I guess that's upon reflection, I was the NHS sort of a frontline midwife. So I guess maybe that was my only risk factor. It's difficult to tell. My first symptom of COVID, again, I never actually had any respiratory symptoms. So for those of you joined on the call that also didn't have any respiratory symptoms, I'm sure you'll know how that feels, because again, you're constantly being fit into a box that you can't be fit into. I remember being in hospital and I remember being very, very unwell. And I remember doctor saying to me, well, you don't need to go to intensive care. You don't need a ventilator. So you can't be that unwell with COVID. And I'm sure a lot of people will resonate with that, even those who probably couldn't even access the hospital in the first place, probably because they didn't have respiratory problems. The headache that I have or did have at the time, I still live with, which is very difficult. So that's one of the many symptoms which I won't list here, but as I'm sure all of you will recognise, a lot of the symptoms are persistent. Some do come and some go, and there is sometimes absolutely no rhyme or reason for it. In the beginning, I self-presented to the emergency department in total of 4 times within the first 6 weeks of my COVID infection. Again, that is completely unlike me and unlike someone who is sort of fit and healthy. So again, as I reflect on the journey, again, that's just another highlight of how difficult it was at the time. I was completely incapacitated for months on end. I get a question a lot around how did you know that you had long COVID, or how do you know when did it turn into long COVID? And again, I'm sure a lot of people will resonate with this, that for me, there wasn't a particular day that all of a sudden, oh, I've got long COVID today. And actually, I think some of the doctors that support me to this day would probably agree with that. It just sort of ended up that way. A lot of us, the days turned into months and the months turned into years, and that eventually led to the realization that I guess it must be long COVID, which has been incredibly difficult. On that note, a lot of us at the start and also throughout this entire 4-year period have wanted to advocate and wanting to, of course, be better, find support, rehabilitate, and find some sort of treatment for long COVID. So that led a lot of us to want to contribute to LOCOMOTION. So I feel really glad to be here today to talk about that. Next slide. So the LOCOMOTION study and the research and all the work packages have been developed with patients, as we are equal partners, and so it should be across all healthcare research. Because I did fit the criteria, I guess, for the work package of health and inequalities, I was able to have the opportunity of actually being an active research participant. So sort of, I guess, experiencing it from the other side, which was, it was difficult. It's always difficult talking about how long COVID has and continues to affect me every single day. But equally it has been an interesting experience as well, being a patient representative for LOCOMOTION. I was also working with Dr. Claire Rayner, who is also a patient representative for Work Package 1.3, and together we were able to support the development of the interview tools that we used. We also played an active role in the recruitment processes, particularly signposting to diverse marginalised communities, which I'm sure Dr. Jordan Mullard and Professor Ghazala were grateful for. And then last but not least, we've also had the opportunity of being a patient author, reviewing and contributing to papers. The one that I've recently contributed to, as you'll see here, You're Just a Guinea Pig. It's not quite ready yet, but it is forthcoming. So once it's published, then we've got all of your contact details, so we'll be sure to send it out. So thank you very much for listening. I'm now going to pass over to Dr. Jordan Mullard.
Thank you, Sophie, and thank you for sharing with us your experiences, which I know are difficult to talk about. And we've really appreciated your input into 1.3, which has been really valuable. And really underpinning the work of 1.3 is this idea that without co-production, we're not going to get the best clinical practice. So in order to achieve that gold standard, which is the focus of locomotion, we need to be able to involve those with currently limited access or poor outcomes from long COVID clinics. So one of the ways in which we did that was to purposefully sample our participants from what the NIHR called underserved communities, which involved deprived, ethnic minority, homeless, traveller groups, Gypsy, Roma traveller groups, or people with a disability. So we had a really good geographic spread for our cohort that went all the way across North and South England, the East and West, Wales and Scotland. So we were very grateful for being able to achieve that. Principally, our methodology was through qualitative interviews, and we also carried out a survey of the different clinics that are part of the LOCOMOTION group. And we also fed into some of the other work packages around the gathering of primary care data, because as we'll go on to talk about, some of the key barriers to access for treatment are focused at that level of primary care. But we'll go on to explain that in a bit more detail soon. So in total, we interviewed 18 key informants, what we call key informants. And these were experts with relevant experience in long COVID, service provision, design, as well as a focus on health inequalities. And some of our those informants in particular had done a lot during the pandemic looking at health inequalities. So that was a really interesting cohort to explore how they felt about the current understanding of long COVID, and particularly in terms of health inequalities. We also interviewed 23 participants from these underserved communities that were not accessing long COVID clinics, but did in fact have long COVID symptoms. We also received the feedback from 10 of our clinical sites that fed into sort of quality improvement. So they were feeding back what kinds of initiatives they were implementing with regard to making their services more inclusive. And Ghazala will go on to talk about that in her section. So we also used a kind of thematic analysis to look at the data that we received, and also fed again into that analysis of the primary care data, which was really important. And I think Ghazala will talk a bit more about that. Next slide, please. So to begin with, I'd like to talk about what some of the key barriers to treatment and support were that came from our participants. Many participants, and I'm sure for those of you who are in the audience that are experiencing and living with long COVID, may well also feel this as well. But many respondents cited that they didn't feel heard by healthcare professionals. And we have a few quotes here depicting that experience. Very often, our respondents felt that their experiences were brushed aside and were not kind of taken seriously. There was often a very generalized response. So as you can see from this particular quote, you know, the response they received was, well, everybody has these symptoms. And and that our respondent in this case felt, well, I don't really care about everybody's experiences. I want you to treat me as a person that's in front of you displaying these symptoms. There was also, and I think this feeds into what Sophie mentioned, a real fear of discrimination. And that actually presented itself as a barrier for lots of the people that we spoke to, and weren't entirely sure whether they were being discriminated against in terms of that access issue. We did have some informants talk about how they felt they were treated differently to perhaps other people in the GP surgery that they witnessed. And I think it's these kinds of things that often go unrecognised when we talk about ethnic minority experiences or disproportionate experiences in terms of access. And I guess it's that kind of an additional layer that ethnic minority people living with long COVID, along with other conditions, have to think about as part of their pathway to getting the treatment and support. That sort of not really knowing whether discrimination is at play or not. And as this informant talks about, there's lots of editing and censoring that goes on. And especially in those sorts of professional environments, talking about that inequality between the patient and the healthcare provider. One of the other barriers to support were around the failure to refer. And that once they received the GP appointment, which was quite hard to come by for many as well, they then felt that they weren't referred effectively to any kind of long COVID service. And in fact, as the title of our forthcoming paper is, comes directly actually from a quote from one of our respondents who said, well, you're just like a guinea pig, and you never quite know whether the kind of offer that you're being given is actually going to meet your needs. Some also cited the lack of trust, and I guess this for some had quite deep-seated roots relating back to the pandemic, vaccination rollout, etc., and a real sort of, well, there's been so many mistakes in the past, and how do we know that we're actually going to be treated fairly and appropriately? And also a lot of respondents, and majority actually felt that they received inadequate advice. One respondent was told, oh, you just need to rest, you just need to work less. And this respondent felt like, well, I can't, can you tell my boss? Because I can't just, work less. I need to work, I need to earn money. So there was this kind of sense that their real needs weren't being met. Next slide, please, Tom. So some of the key impacts really that people talked about were things around the sort of ability to work. So the ability to work, the experience around work, fear of losing their jobs. And out of the 23 people living with long COVID that we spoke to, 11 were still working. For many of those, they were working as freelance or self-employed people, and they felt that they couldn't stop work because if they did, there would be no income or no support system in place for them. A lot of people talked about the physical impacts and the living with not really knowing, is this long COVID? Is this not long COVID? I'm not receiving any support. I don't know what's wrong with me. And the kind of pressures and stresses that induced. And we'll talk about that a bit more in the next slide. And also the exhaustion and just, physically feeling unable to fulfill the tasks of life and live life to the fullest. And we'll talk again about that. In addition to that, people talked about the psychological and emotional impacts. And in part, this was about living with a series of symptoms that weren't being recognised and not being heard when you did try and raise the issues that you were experiencing. And some of our respondents were seeking mental health support at the time. In addition to that were impacts on social roles and family life, which was a great impact for lots of people, where once they would have been a very active parent, for example, caring for young children. They found that the physical symptoms and the emotional symptoms really impacted on their abilities to care for children, to fulfill various different social roles. And it really became clear that these kind of impacts combined really led to avoidance. So people were often choosing not to engage socially for fear that they would feel very tired after doing so. And there was this kind of constant weighing up of, well, if I input this amount of exertion to fulfill a social role, I know it's going to take me days to recover. And as a result of that, and many respondents felt quite lonely and quite isolated. Next slide, please, Tom. So one of the things that we've been doing in terms of analysing the data, and as Sophie mentioned, we have a paper forthcoming on this, and we have another one in the pipeline on some of the material that Ghazala is going to talk about. But just to think through some of the analysis. So I think the biggest issue that came out was what we're calling this diagnostic odyssey, this journey that people have to go through in order to get a diagnosis in the first place, and how that has a lot of different consequences for people's lives. And in a sense, we're wanting to kind of look at this as a form of disruption. You know, it's a disruption of people's normal everyday lives and the quality of life that they have. And these came out really strongly as key themes. You know, as one respondent said, you know, I worked and I lived and I socialized, I went on lovely holidays and I just enjoyed my life. And then one day that was all taken away, and it was very abrupt, and that nothing has ever been the same again. And it was really powerful hearing that there was this real sense of a disrupted life. Another thing that we wanted to sort of unpack was this kind of lack of long COVID knowledge and a frustration that respondents felt like when they were going to seek support, that actually some of the healthcare providers really didn't know much about long COVID. So in a sense, they felt quite sympathetic. Well, how can you diagnose something that you don't know anything about? But that put the patient then in this quite difficult situation of having to explain to the healthcare professional where they think their symptoms originate, and that not always being received terribly well. And that really, when you're living with multiple disadvantages and inequalities, this, you know, having to fight to have yourself heard in terms of your experiences and symptoms becomes yet another form of work that you have to do, another form of labour, really. So really, in terms of some of the key concepts that we're looking at in analysing our data, there's this question of validation and having your symptoms validated by healthcare professionals as being fundamentally important on one level. However, some also did feel that being labelled as long COVID also presented a series of problems as well. And that was particularly true for those that are classed as the sort of long haulers. But there's real issues around invalidation and living with that feeling that, you know, you haven't been heard, and the kind of tensions that created. Next slide, please, Tom. So that's it for our section, and would like to open up the floor to any questions on the patient experience. And I'm sure others on the panel will chip in as well to help answer them. Thank you very much for your time. I think, are there a couple of chats in the chat?
There is a question about well, it's more a comment that GPs actually don't know what to suggest or know the key platforms, and I think that's that's actually a really important point, that patients often had to do their own research to find out what was going on, and ask for referrals, as Jordan just mentioned there, rather than getting that information from GPs themselves. So that is a huge issue, I think, in terms of ways forward. And somebody else mentioned training for GPs when funding for, I think, is that peer support groups, peer counselling and support, PCAS. I'm not really sure what it stands for. But
the post-COVID assessment service.
Oh, right, the long COVID clinics. Okay, right. So I think, yeah, if they're coming to an end, it's going to be that they were the ones who were doing the training, and it wasn't even all of them. It was a very small number of them that were doing any training for GPs. But yeah, that's definitely going to be one of our recommendations from this project, is that there is need for training for particularly GPs, primary care practitioners more generally. What education and training do you think GPs and practice nurses need? Sophie, do you want to have a go at that? What kind of training would be helpful?
I've always actually said that there should actually be universal training, not just for nurses and doctors, but also different, so like allied health professionals, physios, OT, healthcare assistants. I've also always thought that given the severity of the ongoing pandemic, that we should actually mandate the training, because what we've been hearing as patients is that those that do actually access training for long COVID, it's sort of seen as an addition to their continued professional development, rather than sort of any form of a mandatory training as you would with adult resus, as an example. You know, given that the pandemic is global and it's affected thousands and millions of people across the globe, it's crazy to me that there isn't really much in the way of any form of universal training, both in this country and globally. So that's what I would add to that question.
Yeah, I think that just having a sustainable model of training as well is probably really important. Jordan, please carry on.
Yeah, no, I was just going to agree with that. Having something that is sustainable and that can be rolled out quite systematically and inclusively would be really, really important. And I think that feeds into the second question from Janet Murray about what you do if you've been referred to a particular specialist, but your issues are dismissed and then you're sent somewhere else. And I think one of the things that has come out of our research is that the provision within clinics is very variable. And we know that there are areas of the country that have not had any clinics. So, you know, I think that experience is something that has been shared more widely. It could be worth, I mean, I can't sort of advise specifically on your case, but one of the things that some respondents talked about was, you know, returning back to the GP and then doing their own research, finding out where there were clinics, and then asking if they can be referred in to those. So it could be worth trying to explore that route. I don't know if anybody else wants to come in on that question.
Yeah, I just wanted to add on that question, actually, Jordan, Janet Murray, to actually say that, well, if patients are actually getting referred to other services, either chronic fatigue service or fibromyalgia, actually it is a good thing, because I think, as I've just responded to the other question, is that our understanding of post-viral syndromes has actually is much better after this pandemic and after managing long COVID. And we are now actually starting to understand even chronic fatigue syndrome and fibromyalgia much better, because these two conditions were, again, you know, always disbelieved and no specific biomarker. Now, these, again, they are post-viral syndromes. So I think if people are getting referred to other places, it is actually a good thing, because I think that will educate professionals in other services more about these conditions. And as I was saying, hopefully the professional society, which is coming up from next month, that will bring all these clinicians together, and there will be some joined up thinking about these conditions. So if the conditions are all same, having all these different labels actually is not very helpful. Whether you want to call it chronic fatigue syndrome or fibromyalgia or long COVID, I think, they all are under the umbrella term of a post-viral syndrome, which has got a pattern. So as long as that pattern is well understood by clinicians and there is proper validation and there is proper recognition and treatments, that is good for the whole field, because you clearly can't ignore about 200 million people all around the world struggling with this condition. Now that's just long COVID. So if you add 5% of global population with fibromyalgia and about 0.5% of chronic fatigue, you're talking about billions. So that's amount of people struggling with these conditions. I think whatever is happening is actually for good, as long as there is better understanding for the condition. And I think patients have a huge role to play as well in advocacy, to bring all these conditions together.
I think with long COVID, though, what often has been happening is people have been referred to multiple clinics for their symptoms, and there's nobody with the oversight. And one of the questions is, how do you get an official diagnosis when you're being sent to these multiple clinics and they're all treating you separately? Nobody's actually treating it as long COVID. And that's a problem from the patient point of view, because nobody is actually treating it as long COVID. They're all treating it as a separate symptom. So I think what you're saying is the aspiration, isn't it, Manoj? But there's still a long way to go.
Yeah, and also in terms of the terminology, I think, as long as you get a diagnosis of a post-viral syndrome, I would say that is a good thing, because at the end of the day, it is a viral illness which has caused it. So they shouldn't be actually labeling it as, a functional symptom or an FND, which is actually not properly validating it. So as long as the diagnosis is a post-viral syndrome, I think it's good.
Yeah. Do we have time for any other questions, or shall we move on to?
I think you could answer a couple more if you've got some that you particularly want to pick up on, Jordan.
Yes, there was one in the chat about lived experience and the role of healthcare providers with lived experience of long COVID. I think the person in the chat, was it Alison Bird, as an OT with long COVID, and the kind of insight that might bring to delivering care for people living with long COVID. I think we actually did a systematic review. Sorry, my cat's just jumped off the windowsill and fallen. We did a systematic review looking at the role of peer support, and I think that has come out as showing it to be very, very powerful in terms of giving people the space to talk about their symptoms, and having healthcare professionals with lived experience, I'm sure, brings a lot into that experience for people who are coming to clinics. It's also good to hear some good news stories as well about positive experiences in the chat. So thank you for those as well. I think we can move on to...
just before we do, I was just going to pick up on the question from Helen. People are not generally testing for COVID, but may present with symptoms. And I think this does seem to be impacting on diagnosis or delaying acceptance. I think there's a whole issue around health literacy within disadvantaged communities, and how much they actually might realise that this is long COVID that they're experiencing, and particularly without tests, that can also impact on practitioner willingness to call it long COVID. So I think there are issues there that we've picked up within the interviews that we've had too. But yeah, we can move on now if that's all right. Yeah, thank you.
Okay, thanks very much, everybody. I'm going to hand over to Professor Ghazala. Thanks.
Right, so I'm going to be talking about what we found out from some of the other data sources, speaking to long COVID clinic leads, and also looking at the patient interviews and some of the key informants. So what did people do when they weren't getting the support? This was one of the areas that we looked at. And often people would try to do their own research about what support they might be able to access, or groups they might be able to join. And if people were part of the NHS staff, as Sophie herself mentioned she was, they were more likely to be able to obtain this kind of knowledge about long COVID treatment and support, or if they had somebody in their family who had those kind of contacts, They could ask a colleague or a doctor who might know somebody else to give the referral criteria, and they could bypass the GP route. Otherwise, they recognised that they would still have been in limbo. Those who didn't have that kind of connection often found that they were just getting nowhere. The level of persistence that was needed by those who did manage to get through to GPs and to get referrals was really very high. You know, people complained about not being able to get through even to speak on the telephone. As we know that the pressure on GPs really increased quite a lot during the pandemic, and that still seems to be the case. And then health literacy, in that second quote there, you can see one of our key informants saying that a lot of knowledge that might be missing within disadvantaged communities, and the biggest driver about who is self-reporting and who can advocate for themselves is actually, knowledge about what is going on. So those with more knowledge are more likely to get the referrals. Other ways that people tried to just manage their symptoms and what was happening to them was to stop their work patterns, to try to do less and sign off of a lot of things, as the person there mentions. What people were saying really needed to happen was that they wanted that overview of care, as I mentioned, rather than being referred to multiple clinics. Although that might be helpful in terms of the individual symptoms, it was not being treated as a whole kind of issue in its own right as long COVID. Often they were being monitored by primary care practitioners rather than getting treatment. And even within secondary care, that was often the case. They're being monitored rather than being treated. And GPs, they felt, needed to do more to liaise with their employers so that they could actually return to work, because employers needed to have more information about what long COVID was and how it would affect work. And where there were employer support networks, as in the NHS, these weren't always consistent. Sometimes people would get quite good support, and other times they wouldn't get much support at all. Next slide, please. So when we spoke to the long COVID clinics that were involved in LOCOMOTION, we found that there were a number of issues that they were having to deal with. First of all, in terms of who was actually attending the clinics. So knowing who was attending, whether it was people from disadvantaged groups, and a good spread of the population or not, could only really be found out if they actually started to look at their data. So making inequities visible was really a first step in trying to develop good practice within those clinics. So looking at the data to identify which groups might be excluded, which might need to be prioritized in terms of targeting the service, and to tailor services for those groups. So it was commonly reported that people from deprived areas, people from minority ethnic groups, people from learning disabled backgrounds, people with disabilities were often not represented adequately within the clinics according to the local population. In fact, I don't think there were no clinics that actually said that they had somebody from a learning disability background, somebody with a learning disability. So it was actually really worrying that they were not able to get any referrals from that group, when we know that that's a group that actually has higher rates of long COVID. And what they would do then is try to work with GPs in deprived areas or in areas where there were higher concentrations of people from minority ethnic backgrounds, to give them some training in what the symptoms might be, to target GPs and encourage them to refer. They would also work with third sector groups, voluntary sector groups, which are more approachable and more accessible to people from disadvantaged backgrounds, and involve them. In Leeds in particular, they were trying to involve them in the pathway that would lead to a long COVID referral. And just to help them navigate the support that was available. So third sector groups were able to give the kind of information that might not be forthcoming from other areas for people from these backgrounds. And then the low awareness within communities themselves, the fact that they might not even recognise that they had long COVID, or identify the symptoms as long COVID, or even know what support was available. This is being addressed by some clinics through working communities, outreaching through occupational health and human resources, reaching out to those kind of providers and using influencers within the communities to try and get the message out. Another thing that was being reported was long waiting times for referral to clinics once a referral had taken place. So that waiting time could be used by passing on information to people on the waiting list, giving them opportunities to find out more about peer support and other kind of support while they were waiting for specialist care to happen. Geography was another issue where people might not be able to access the clinics because of where they were located. We might have one clinic in a rather large area. It might be difficult for people to access, especially if they weren't within urban settings. So having diverse clinic sites, trying to have outreach clinics as well, satellite type clinics could also be another option that some clinics were doing. And then other types of barriers to access related to finance and capacity. Some clinics were offering a choice of virtual visits, face-to-face or home, depending on the needs of the individual patient and tailoring that to their needs. Signposting to IT support and equipment that might be able to help with digital exclusion. And then also financial type of support through benefits advice, not necessarily providing that advice themselves, but signposting them to organisations that could give benefits advice and support grants, as well as food banks and advice on housing. Next slide, please. So in terms of good practice in treatment and management of long COVID, there were two very clear kind of recommendations that were coming out of the different data sources that we looked at. One is that we really need to move beyond monitoring symptoms and to refer for specialist care if symptoms fit the profile for long COVID. And what the profile is becoming more and more recognized. Now we're getting more and more information about what the symptoms of long COVID are. And to be flexible, recognizing that as research develops, we might need to adapt the care and recognize needs that might not have previously been recognized. See this as an evolving service where new pathways need to be established, and to do that through trial and error and see what seems to work best. GPs liaising with employers, providing more support for people with long COVID to actually return to work in a phased way, giving information to employers about what might be helpful to people with long COVID. And then, as I've said, more consistency across NHS organisations that were providing support networks. And then, again, to reduce the fragmented care, just coming back to the idea that being referred to multiple clinics is not necessarily seen as helpful by people with long COVID, that in some areas there were some multidisciplinary and multi-sector teams working together. And they were triaging people who were coming through and tailoring the care pathway to provide a more holistic level of support. And this could reduce the adverse impact of being referred to multiple clinics, all of which had long waiting lists, and especially for people who already had high levels of existing ill health before they got long COVID, that could be really important. And in terms of comorbidity and self-management, having a single sort of point of contact with somebody overseeing this as long COVID rather than a series of different symptoms could help with the uncertainties that people felt and help them to get advice on the changing needs that they might have over time with self-management of their symptoms. So I think next slide is just questions on the recommendations, and we can go back to some of the other questions if that's helpful. So I'm just looking at the questions that have come through now. Yeah, I think what Catherine Patience is saying here is really true. Having somebody with oversight of the condition, as you say, it looks like you've been seen by long COVID service, but yeah, the extent of how much support you can get if the condition is still ongoing, but you're not getting any support to help with that. That's really just reflecting what people have been saying to us, that they need some continuity in the support that they're getting. And somebody with that oversight, I think that's absolutely right. Any other questions that anybody wants to pick up on, Sophie or Jordan? Anything particularly surprised you while working on this research?
I answer that? Or
Yeah,
come
of
in
course. Yeah,
on
please
that?
do. Yeah.
Yeah, that's a really good question, because I think when I started the research, I wasn't really expecting to hear the amount of people that I heard say the same thing in terms of, you know, not getting referred. I was quite surprised by that in some regards. And I suppose during the course of the research, we started to unpack the reasons behind that. It became quite clear that I think for lots of GP, and this feeds into another question about the sort of variable knowledge at that time. So, when we began the research, 2021, wasn't it? That there wasn't a lot that was actually known about long COVID at that time, and that was part of the issue. But then there were lots of people who had been living with those symptoms for a really long time as well, and it was that kind of tension between the two. So that was a bit surprising in some respects. But it was interesting as the research progressed, how the issues for those who have been sort of more recently contracted COVID and developed long COVID, their experiences were slightly different. But positively, the clinics that we worked with in LOCOMOTION were all really, really motivated around the issue of inclusion, weren't they, Ghazala, in the sense that they wanted to be doing the right thing and they wanted to be as inclusive as possible. So that I thought was quite optimistic.
Yeah, I think it's what to do is how can we become more inclusive is the question that everybody needs to wants to have answered, and I think we've provided some pointers. One of the surprising things for me when we first started working on this study was to find that there was an underrepresentation of people from minority ethnic communities reported by the Office for National Statistics in terms of long COVID, which is really surprising, given that there was so much overrepresentation of within COVID-19 prevalence. And I think more recent studies are actually finding that if you look at symptoms rather than self-report, so the ONS study was done, or the ONS data was based on self-report. If you look at symptoms, you find a different kind of picture. And also more recent studies, we're also finding this from one of the work packages in LOCOMOTION. That's still preliminary analysis, but looking at GP data, it does look like there is over representation of people from deprived areas, people from minority ethnic communities in primary care records. They might not necessarily be being referred at the same rate to long COVID clinics. So I think this is something that we need to sort of take a bit cautiously and recognise that health literacy can play a big part. The lack of testing can also play a big part in how much long COVID is diagnosed within primary care. And we really need to keep an eye on the research with this. I think it's coming out more and more that there are higher prevalence rates within minority ethnic communities, but it was a long time coming, really. So that was quite surprising to me. Another question here from Sue Birch was about accommodations from employers. And I know this was something that some of the clinics were working on, trying to work with employers. What we found was that with the disadvantaged groups that we worked with, that we were interviewing, they often had quite negative experiences of trying to return to work. If they were often on insecure contracts to begin with, so didn't have that kind of support from employers. If they didn't manage to make it to work, they often lost their jobs. People who are self-employed also didn't have the same kind of structures where they could rely on support. And then we found some people saying that they felt they were treated differently from other people with long COVID within their organisation. So there weren't very many accounts of good support from employers within the sample that we had. Jordan, I don't know if you can think of any good practice that came up.
Sadly, not really. Oh, there was no. That's not true. There was one educator, and they'd mentioned that their employer had been quite understanding, and had kind of put in provisions for things like phased returns and that sort of thing to come back and get back into work. But yeah, as Ghazala says, a lot of the experiences were not particularly positive.
Yeah, it's a good.
To add on that, sorry, Ghazala, just to also add on the employment front, there is another work package, Sue, that's also directly involved with what we call vocational rehabilitation and sort of working to help the individual get back to work safely whilst living with long COVID. So do watch this space, because there'll be some more information about that coming out soon, where there will be a little bit more positivity in terms of those that have been successful with returning back to work with long COVID, because there are a couple of success stories, and I know someone else has popped in the Q&A about sort of positivity and, you know, do we know of anyone that's actually recovered? I don't know if there was anyone on this work stream that had actually started to get better at the time of interview. I don't know if there was.
There was one that was starting to get better, they felt. Well, it was debatable. On the one hand, they thought they were getting better, but then they also wondered whether they were just getting more used to living with the symptoms and better at managing it. So it was a fine line for many, I think, being able to sort of self-manage. And I think that was something that came out quite strongly, that because most of our cohort hadn't received a diagnosis, they were having to try and keep going. So for many, they were like, yes, I do have these symptoms. Yes, this is hard, but I can't stop. I've got to keep going. And I think, you know, the long-term effects of that, you know, we don't fully know. And that kind of toll on the body of trying to keep going, we don't fully know what that looks like yet.
Yeah, and there are some questions here about publication and getting the message to government. So we have tried to really focus on what good practice we could identify in terms of the ways forward. So not just to paint the picture of disadvantage and not really move on from that. We really need to think about how can that disadvantage be addressed in the way that you know, some of the questions here are kind of pointing to. We hope to publish this, our findings around good practice in the clinics that we engaged with that are within LOCOMOTION in a practitioner journal. I mean, I think the piece that Jordan and Sophie mentioned, the paper that's about to be published soon, is very much about looking at this from understanding this in a way that's theoretical as well as you know, just bringing out patient experiences. But we need to also have something that is really very much focused on practitioner actions. So I think the link to that kind of publication is we will be looking perhaps at the journal like the British Journal of General Practice or something like that to try to get those findings out, and linking also to the previous publications. Yeah, so I think any other questions that people want to pick up on?
In terms of positive messages, just to go back to that, we're in the process of writing up some of the data on a work stream that looked at peer support. And having got my head into all of that data now, there are some really positive messages coming out about what works in terms of peer support for people living with long COVID. So I think that would be quite an interesting paper for people to look at, and for us to publicise, because it seems that peer support, and we know from you know, long COVID support groups, that they can have a real benefit to people. So that's something quite positive to think.
Yeah, the paper that we're putting together actually has 2 case studies of long COVID clinics that are doing the kind of work that we sort of identified as good practice. And I think that should give some really good pointers to others within primary care and within long COVID services, or anything that links to long COVID services. One of the questions here was about psychology services that support the long COVID teams. And I think we got very mixed kind of data back about the psychology services. Some people that we interviewed felt that their symptoms were being dismissed as psychological, whereas actually they felt they were very much to do with physical symptoms. So I think we have to be, sort of careful about how psychology services support the long COVID teams in ways that are holistic and allow people to get support for all the different symptoms that they're experiencing. Anything you want to pick up on, Sophie, in the questions?
No, I was just having a little look at, there's been a couple of suggestions from Alison Bird, thank you very much, which I think has been greatly appreciated. Mainly just sharing the Society of Occupational Medicine guidance in regards to vocational rehabilitation and adjustments for going back to work or working with long COVID symptoms. Just having a little look through. Don't know if there's
we've had a paper recently accepted, I think it might be in the publication process, on vocational rehabilitation and long COVID, haven't we, as well?
Mm.
Also, just to say, if there are, we will go back and have a little look through all the questions again properly, and they will be answered. So any of the questions that we haven't directly answered today, this is recorded. So it's going to go onto YouTube, it's going to go onto the LOCOMOTION website, and the sort of other questions that haven't been answered, there'll be an answer there as well. So really sorry if we didn't get round to everyone's questions, but we just wanted to say a huge thank you for asking us and engaging with the Q&A and for attending today as well. So thanks all.
Yeah, and just to finish maybe on this question about from Alison Twycross, who do you think is best placed to provide oversight of care? I mean, Manoj may have some something to say about that, but from the patient point of view, I think they want specialist care that is actually continuous and joined up. But yeah, Manoj, please.
Yeah, I think that's a good question actually, and I would definitely still think that GPs are actually best placed to be the primary kind of care holders and care coordinators. There are definitely issues in terms of recognition and the time they can spend on these conditions, but clearly I think we need to provide more support to primary care because realistically, I think in future, the care will be more primary care focused. But what we really need to work on is the link, which is missing between primary care and secondary care specialists. In terms of, as in the chat, somebody posted about the respiratory investigations need doing, the cardiology investigations need doing. So they were all set up nicely in long COVID clinics, but now that the long COVID clinics are kind of slowly winding down, I think the links with the relevant specialists need to be maintained via the GP. So I would still say GPs are the core for managing this condition with relevant sort of links to the specialists. And finally, the post-COVID society, which is being set up. So you want to probably look up Clinical Post-COVID Society. So it's a professional society which brings all the clinicians together. It's funded by NHS England. And I think more and more GPs need to sign up there. And the more larger the platform we have of medics and allied healthcare professionals managing these conditions, I think it will lead to further, validation and research in this condition. And that is the way we're going to address this, more kind of professional networking. And the more people, the more critical mass we have who believe in this condition, only then we'll be able to move this forward. And I think that's about time, actually. Sorry.
That's great. A great thing to end on, I think.
Yeah, brilliant. Thanks, everybody. Thanks for coming.
Thank you all. So there will be another webinar, and please check on our website, and that will be next month. So the dates should be there, and then you can register as well. Thank you so much. Thank you all.
Thanks all.
Bye, everyone.
Bye.